Thank you, Bruce, and thank you to the organisers in Australia for asking for the NHS England VTE Prevention team to contribute to your conference on preventing and managing VTE. As National Clinical Director for VTE Prevention for the NHS in England, I'm very sorry that I'm unable to be with you, but I'm delighted that with Roopen Arya, as the Director of our National Exemplar Centres Network and a key national and international advisor on VTE prevention, you certainly have the best man for the conference and for the workshops. But first, can I introduce myself? I'm a consultant anaesthetist and for the last 20 years have also been a medical director, first at the system level, at hospital level, and more recently for NHS South of England. My involvement with what was to become a national programme started nearly 5 years ago when, as a member of a fledgling core team of the National Patient Safety Campaign, I was asked to talk about the aims and aspirations of that campaign at a conference organised by Salisbury Hospitals. I was convinced by what I heard that there was an unequivocal need for action, but I was also convinced that without a coordinated and collaborative effort, the individual efforts would not make sufficient impact on the whole. We then designed and delivered the whole system approach to VTE prevention across all hospitals in the southwest, covering a population of 5.5 million people through a peer review methodology, which was owned and led by a lay and clinical community, but that also significantly had the mandate of the chairs and chief executives of the hospitals and primary care trusts of the southwest. Through the earlier initiatives of Sir Liam Donaldson and Chief Medical Officer, and the scrutiny brought to bear by first the Health Select Committee and then the All-Parliamentary Group on the impact locally of his reports, it became clear that not a lot was happening to prevent VTE harm and in too many cases needless death for thousands of patients. The drive for an improvement in this state of affairs was foremost led by a Rainbow Alliance representing families and carers of those harmed to form many focus groups and also significant national and international third sector-led organisations. However, the lack of local action to implement evidence-based interventions to reduce this harm was to mean the continuing needless deaths and long-term incapacity of thousands of patients. But what did happen was that groups of committed individual professionals were galvanised to come together and lead on a number of initiatives which together enabled the elements of a large-scale change to happen across England. There is no question that without the energies of colleagues working within NICE, we would not have had some of the key instruments we needed in place to implement a national programme from 2010. There has also been specific and sustained involvement by the NHS Medical Director, Sir Bruce Keogh, who you just heard from, who drove through the development of the National VTE Prevention Sequin goal and the rigorous mandatory data collection for VTE risk assessment. The initiation, development and designation of the Exemplar model for hospitals by Roopen Arya and his colleagues has ensured that there is a growing, committed community of leaders who are continuing to set the bar high to ensure that the highest standard of care and intervention when needed is taking place. So where has this taken us and what has been achieved so far? A leadership position taken by Bruce Keogh, who last year made VTE prevention the top clinical priority for the NHS. Building on their comprehensive clinical guidance, NICE has formulated the first quality standard for VTE prevention, which has enabled the development of a national sequin, which is an incentive payment for those hospitals that have achieved a sustained improvement in the percentage of patients who have been risk assessed. This is currently set at 90%. The development of a national model of risk assessment that allowed and supported local improvement. The incorporation of the risk assessment pro forma as a standard record to be held securely within the medical record. The use of a medicines prescription chart as a very appropriate record of the risk assessment, and the use of a national cohort approach linked to the NICE clinical guidance has enabled the local team to concentrate their efforts on ensuring that an appropriate and recordable risk assessment has taken place that is both meaningful to the patients and transferable in terms of assuring the use of appropriate prophylaxis. And finally, the use of root cause analysis to identify where in the pathway did an event take place and what was the learning that should be shared. Nearly all hospitals are now submitting returns confirming that well in excess of 90% of their inpatients are having a risk assessment, and their staff and leadership teams deserve a huge credit for this achievement. The response to the call to improve the risk assessment has also been a spur for innovative solutions in data handling and collection, as well as the development of aids for teaching and training. And yet again, in so many ways, healthcare is in the debt of Steve Jobs for his talent in developing a platform that people love to use rather than see technology as a barrier to involvement. But I would like to ask, why is it that despite now having embedded systemic and systematic approaches to the risk assessment of VTE for hospital inpatients in England, I believe we have much more to do. I think we still have much more to do because of three key failures in our model of improvement to date, and our challenge will be to eradicate the cultures and behaviours that continue to allow these failures to persist. We must rise to the challenge that allows and accepts that too many clinicians fail to implement evidence-based practice, and we must implement a sustainable and resilient method that ensures that all appropriate patients receive not only an expert risk assessment, but also the most appropriate prophylaxis. We must challenge the leadership of hospitals across England at senior management and board level to set the ambition of harm-free care and charge them with the drive to constantly elevate the expectations of their staff. They have a very hard role to play, but with that responsibility that comes with their role also comes the accountability to lead not only their organisation, but also the healthcare needs of the community that that hospital serves. We must build a whole system that learns from its errors, analyses the causation, and ensures the spread and adoption of the learning that has been gained. The system is more afraid of adopting the best practice of its near neighbours than it is of quoting what should happen. Much of the rest of the world looks to NICE for the instruments of best practice, and it is for us to ensure its mandation within commissioning contracts. There is no doubt that as we have moved the system to concentrate as much on the measurement of the outcome of care as on the process of care, we are very much in the innovation space as far as an outcome measure for VTE is concerned, and enormous efforts are being made to ensure that appropriate indicators will be in place when we publish the next set of indicators for the NHS Outcomes Framework. Although accurate and consistent coding is essential, the answer will not rely on coding alone. We now have a new architecture being developed for the commissioning and delivery of health services in England, and core to delivery of this reform is the development of the Commissioning Board for England, which will hold the responsibility to lead the commissioning of a health service within the NHS Constitution and the Outcomes Framework as key instruments. But also within this new model, we must ensure that we deliver the appropriate operating model for delivery of a clinically led health service that has high quality outcomes and the transparent public reporting of information at its heart. A vital component within the leadership of this new model is that we must press hard to ensure that there is the continued and sustained effort to drive out the complacency and collusion of previous generations who believed there was nothing one could do to prevent hospital-related VTE. To this aim, next year's operating framework will continue to include an incentivised payment that will require 90% or greater compliance with risk assessment for VTE, and we will drive to add wherever possible a further exemplar sequin to demonstrate that 90% of patients are also receiving appropriate prophylaxis. We have seen from the data so far collected that there are silent zones in our hospital systems with regard to engagement and leadership, but these also exist across the delivery of primary, community and social care with regard to VTE harm. The development of primary care clusters has brought into the system executive appointments of 50 directors of nursing and medical directors who have the specific remit to ensure that systems are in place to ensure the quality of care offered to their population. The vast majority of these medical directors are general practitioners who will continue to maintain clinical practice. The systems that primary care trusts have in place to manage quality and safety have to date been used variably across England. A major opportunity now exists to set that bar even higher for the quality of commission service given to all our patients. This means that during the transition to a single model, primary care trusts must not only ensure that they are managing the quality of performance of their local hospital and community provider systems, but also they must work hard to drive up the quality of scrutiny of our primary care services. We know that unless we achieve a marked improvement of the understanding and awareness of the harm from VTE within general practice and residential and care homes, any gains that may have been made within the hospital sector will be lost. and we cannot afford to let this happen. Our next challenge will be to ensure that all clinical commissioning groups, regardless of size, must have the capacity and capability to ensure that they are not only maintaining the focus on reduction of harm from VTE, but that they are also working hard across all local providers through clinical networks to increase the patient trajectory of quality improvement. In order to refocus the aims and objectives of the VTE Prevention Board at the Department of Health, we will now be concentrating on three major strategic priorities: to deliver an outcomes framework for VTE, to deliver commissioning tools and expertise for primary care trust, clusters and emerging clinical commissioning groups for high quality VTE prevention, and to support a further drive to ensure an improvement in patient awareness, experience and education. Can I thank you for the opportunity to share what I think will be an exciting delivery agenda that will continue to reframe the large-scale change that has taken place over the last year. I'm looking forward to hearing of the outcomes of your conference, and I hope that you will accept my pledge to work with you on shared objectives to decrease harm from VTE, but also to work on the wider determinants of safety, effectiveness and patient experience in health and hospital care, so that we can continue to work together to eradicate harm from avoidable venous thromboembolic disease. Thank you very much.